I would like to present an overview of these things, which are the medical records audit, medical audit, and clinical audit. This is the idea of this presentation. All the examples given are from Arvind only for training purposes. Don't take it as absolute proof. No financial interest. In 21st century, it is no longer a luxury to improve quality. As Robert Johnson said, it is delivering a promise for quality is mandatory in healthcare, providing a personal touch, and in fact, wherever possible, knowing more than adequate. We don't just say over treatment, taking care of the entire patient as one person and the family, and resolving all the problems that are likely to arise, which are expected in healthcare properly. A process used in healthcare to evaluate and improve care of patients primarily. So, sir, as Sir said, and everybody said, how do we do an audit? Audit is measured against a standard, a defined or probably a desired standard. That is what we do in audit. It is a very good tool for continuous quality improvement and makes it uniform best practice inside institutions and in organizations like us. When it becomes uniform across all the hospitals, it will be the excellence, area of excellence. It not only benefits patients, the doctors and the professionals or the organization also is benefited. It is also a tool for NABH. There are three types of audits. One is called the internal audit, which a hospital does within itself. Supposing some other hospital from within the organization comes, it is still an internal, but it's called the second party audit. And audits like Clinical Establishment Act or NABH are called third party audits. This is very important. Why do we do audits? Because to check the status and to improve whatever standards we have against the standards. These are the standards which are going to determine at what level our hospital functions. How we do? By seeing the documents, seeing the records and interviews. Documentation is a must and record maintenance is a must. If not recorded, it is as good as not done. If you don't have it in your manual, it is as good as it is not a process being followed in the organization. This is something which all of us need to know. When we observe a standard, when we do an audit, there is called conformity. Everybody knows about conformity, and all of us know about this something called as non-conformity, NCNC. There are two NCs. One is called the major, the other is called the minor. Major, wherever the patient's care or any employee safety is directly affected, then it is called a major non-conformity. If the signature is absent or a seal is absent or a registration number, certain things which may not directly reflect to the patient's care and cause major deficiencies, it will be called as a minor NC. Now, regarding conformity, some of the things like, sentinel events, whether we lay 1 lakh or 10, there should be zero. There's no question of improvement. It has to be zero. That is the idea. But we do know when we do medical records audit, it is impossible to get 100 on 100. Supposing we know all of, I think most of you will know this Pareto analysis. If we take 10 records and we have 10 on 10, excellent. It is area of excellence. Supposing we do have at 9, we can still say there is an opportunity for improvement. But if you're going to be at 8, it can be a conformity, but anytime it can become a potential non-conformity. This is the best way to analyze how the standards are based on whether they are major standards or minor standards. This is the background which we need to have and follow any kind of audit. Now here we are going to talk about two major things. One is the physical record and electronic medical record. As at Arvind, we are in the transition phase. No, not completely. We are in the transition phase and there are a lot of questions regarding how to audit the EMR. And the next topic would be about the medical audit and clinical audit. So we have the physical records and electronic records. Whatever it may be, we need to audit both active case sheets and already discharged case sheets. That is mandatory to do so that we will also know anything retrospectively, anything has gone wrong. And currently, if we can find, there is always a chance of making amendments for some of the mistakes. I'm going to rush through this. We have to appreciate that getting an electronic medical record for the system like this is a very big, it's a giant leap. It is going to make many things very, very useful, near paperless. Why do I say near paperless? Even if we have an approved EMR, all the papers that are signed by the patient, all the papers that are signed by the patient have to be kept as a hard copy according to the retention policy of Director General of Health Services and Medical Council of India. It is essential. If it becomes an MLC, again that becomes minimum 10 years or lifelong. So we have to write, that easy to document. Again, when you do it fast in an EMR, there is always a chance of picking up the wrong, whatever choice when you have a drop down menu. Easy and, backup is easy. Then another thing is maintaining medical records for a long time physical will be very difficult. The electronic records can be lifelong, provided we have a good backup of server and you have another server in a remote place. Even if there is a natural disaster, we can have a backup anywhere so that these records are never lost. Safety security is little difficult in the manual system, but we can do it with a lot of protocols and policies. But electronic medical record, there is always a chance of hacking, and somebody knowing the password can always make things. So that will depend on the policy of the hospital. Research work, manual record, collecting data becomes difficult. But in electronic medical record, especially we go with the ICD, international coding, then if you do the 10, across the world it is the same. You can just pick up anything and everything anytime within a matter of minutes. So manipulation, you have to destroy in manual records, which can always be traced. But if the security for the EMR is not properly designed, it can also be changed. Especially in medical legal cases, we have to be very careful. Somebody has given a case record and then after that subsequently there are changes done, it may not stand in the court of law. Confidentiality, again, it all depends on the policies we have, and signature is easy to get on a manual medical record, whereas on an electronic record, none of these scanned signatures will be acceptable in the law. Only approved digital signature by the central agencies will be accepted as a digital sign. So coming now to records, MRD record audits, we have become an expert because of the parameters. I will say our parameters are wonderful to see how we audit the records or any kind of auditing, because we have got wonderful templates. But what we do in the MRD audits, it is done by the paramedicals for completeness, nothing more than that. We do not know whether they have put the correct diagnosis or correct things. We want to see whether it is correct or wrong, entered or not. That's all. Location of entries, where the symptoms should be, where the advice should be, and whether the patient details against fixed standards. So it is easy to do this particular MRD physical record. So these are the things we have. So many kind of parameters we can see against the templates. So OPD records, we see IPD, anesthesia, consents, certificates and leaves, and drug. For example, at Aravind, thanks to Dr. Revati Madam, who heads the MRD committee, in the last 3 years, from somewhere we have already doubled our accuracy and clearness in the various entries, and it has done very well. And all this we do approximately 100 to 110 case sheets, OPD and IPD, including consents per day, and another 50 drug prescriptions a day, every day. So these are regularly presented in the MRD committee, and also the all relevant HODs get a report of this. Only, it is all given only to the HOD. They will know who has made the record. But in the common presentation, we only present the statistics. So this is how it improved, and it was a big boon for us. And these graphs will tell us so many things about how we are doing, how we are not doing, and it is compared with the previous year, previous month, and so on. This is the difficult part of electronic medical record. It is going to be much more difficult to do a EMR audit rather than a medical record audit. We are not even able to do 40% of what our capacity was at Coimbatore because of the difficulty. Certain things are scanned and put, even the registration form, the verification, navigation, it takes a longer time to audit. But if we have a proper, comprehensive, completed EMR system, then the completeness can be ensured by way of creating systems. Then should happen by default, all the entries will occur. But even here, we will not know whether the entry is correct or wrong, but the completeness will be there. So comprehensive AMR should not have any incompleteness. But early stages, we always have some problems. Not necessary. If records are complete, no incompleteness, if you can identify, because login, But the problem is we do not know whether somebody else has logged in. Unless everybody knows about everybody's position in institutions where we have more than 1,000 people, we need to be very careful. And critical alerts again will come by default. All these things are very important. Now, there are sometimes we see, skip essentials like, nutrition, growth, immunizations. There is an option. No diagnosis, we still see records. Today morning a sir called me and told from Madurai, they say pupil 3 millimeter acting to light and so on. After dilatation, the person who's seeing the dilating fundus puts it as, changes it into pharmacologically dilated. So we really do not know the status of the pupil. So the route comes wrongly sometimes, oral will be there for drops and so on and so on. Sometimes we have observed the prescription comes in the name of a paramedical person, which is not at all correct. The critical alert, which is very essential part of any system for any biochem result, 600 of blood sugar or something, sometimes do not show up. So these are certain things which when they get corrected, the EMR will be absolutely perfect. It is not necessary to audit generally what those things I said, but still it is necessary to audit all scanned uploads because we do not know the consent forms, everything for completion. We need to open the forms either from the saved hard copies or from the after signature, whatever is uploaded in the EMR. So that is what I said. Case summaries, which are completed and signed. Every certificate leave, there are rules according to Medical Council of India. I have a certificate, I have given it, I have the photo ID. I take a letter saying that, or in the duplicate, you say, I have received. Even discharge summary, it is always a good practice to say, receive the discharge summary. Tomorrow, they cannot come and accuse us of having not given those things. Drug prescriptions, we still need to continue. And all MLC related case sheets, whether it is hard copy or soft copy, we need to continuously audit. So these are the things I just wanted to talk about the medical record audit and an electronic medical record audit, how our shift will occur as to what we should do actually in EMR. Once our EMR process is evolved completely, then most of the things when we do will be there. But I will come to another audit where we will find out where completeness also will be done. So this lady with the lamp is amusing, right from infection prevention to auditing. During a war, she did the sanitary rounds and found out that hygiene was not good and improved it. And within a short period, they showed that the mortality reduced from 40% to 2%. What a great idea it was. And this person is a true medical auditor in the main, in this era, Ernst Codman. And he did surgical outcomes audit and published it. And it also helped in the institution itself. In India, this A.L. Mudaliar committee encouraged medical audit. In 69, it was introduced in the state to improvise the treatment across, not only the organizations across the state and the country. But I must feel proud to say the NABH, when it got established in 2006, insisted on these audits. There is always a thought that it is not necessary for entry level. It is not entered, not at all so. We as in Arvind, as RDSS says, we do it for improvement, we will do it. Not necessarily only for NABH. Don't do it for that. That is something which is going to help very much in the audits. Now coming to the audits, it can be any standard base. Sometimes we have adverse sentinel events. We do wonderful analysis of sentinel events, surgical audits, peer reviewed audits, or any patient survey of everything is part of the audit, which will help. The NHS is one of the systems in UK which has done wonderful work as far as the audits are concerned. In 1989, they introduced medical audit for patients. But somehow or other, because of various difficulties, it was not followed hugely. Then slowly it became converted into clinical audit, and that is being done very nicely, robustly across the country. 97, it became part of the clinical governance. Now, coming to what I want to say about medical audit, we have to have a standard SOP for any system. For general, you see cataract, you see audio alarm. So 10 common diseases seen in retina, 10 common diseases seen in glaucoma, 10 common diseases in your secondary centers. For all this, we must have a ideal SOP. How we have to take this patient and manage this, what investigation. See, we have to understand there are variations everywhere, but in general, this will be the pattern. If possible, we write in this variation what we will do, where you will not do. This is the standard operating procedure. For an organization, once we do it inside the organization, if there are 10 people in glaucoma, all 10 will follow the same protocol. For example, we say conjunctivitis management, the entire hospital will see conjunctivitis sometime or other. They follow the same protocol, whether it is an antibiotic, whether you want to give a steroid. So this is standardized according to the best practices. This is adapted from the best practices. This is called the medical audit. This is what we do in medical, and it is also a requirement in entry level. Clinical care pathways are developed across all settings. This can be national or international or local, which are approved peer reviewed pathways. It can be adapted and created as per the diseases we treat. And NABH 5th edition says it has to be developed and followed universally across. It is an achievement and excellence. It can be done only by the doctors, because the doctor only will know what is the SOP of particular diabetic retinopathy, retinal vasculitis. So it cannot be done by anybody other than the specialist who knows about the SOP. So to sustain uniformity, this SOP is needed in the organization. Suppose we have Arvind Eye Care organization, if we can make it across all the 14 hospitals there will be small minor variations which are acceptable within normal limits, but this is going to make an area of excellence. You will have the same kind of outcomes, whether it is a primary hospital or a tertiary hospital, everywhere, including our vision center. So this is the idea, and there is always a chance of making improvement based on the outcome. So basically, now coming to MRD audit is done by the staff, whereas this is done by the doctor. Periodicity, everything has been done. We don't do everything. You can take a percentage, 5% of OPK sheets, 3% of specialty case sheets, whatever you define. It MRD sees completeness, whereas the medical audit talks about the management. So we do not know whether it is correct in MRD. We know whether it is correct or not in medical audit. Critical alerts are very difficult in MRD audit. We do not know, but medical audit can make care. Supposing there is a tertiary care organization which has started medical audit now. So the doctor who does, he finds there is a major problem, the right eye cataract, and this is being advised for left eye here. Surgery not done. He can raise a critical alert in the EMR and mark there. Immediately it is escalated to the head of the department and the concerned doctor. So the action can be taken. So this is integrated into the electronic record. The next generation of electronic medical record will be where artificial intelligence will also play a role. For example, yesterday I heard Ganesh saying, if I put cataract and write pseudophakia or write cataract and reft advice, then it will cause an alert. That is artificial intelligence coming into play. We have a long way to go. Electronic medical record has to be a big asset for any organization. Now, coming to the next aspect of clinical audit, it is not a medical audit. Here, you want to make a quality improvement process, as you saw in the first three. The first one was very comprehensive with many standards. The second was, again, was a focused one, and an audit period was there, shorter period. And the third one was comparative, really a comparative audit, and to get the better outcome. All are all clinical audits. Usually clinical audits are done in a short cycle period, not a long cycle period. So it is to define the clinical care and reviewed by doctors predominantly and paramedicals. Usually we say non-medical staff are not involved, but we need them for statistical analysis, all these people. So between medical audit, it is generalized. You take 5% of all cases in a clinic, whereas clinical audit, I will take only diabetic retinopathy if my topic is diabetic retinopathy, not by a peer group and any doctor, but this has to be analyzed by a expertise only. Now medical records and clinical pathways, that are the different things we do. Now here timeliness is seen, care is seen, and the legibility in medical records. Whereas in clinical audit, specific locations are care. I will tell you what it is. Treating doctor, and here we see all aspects of the entire patient care. That is the main thing. Random records in medical records and defined criteria cases will be taken in the clinical audit. Both are planned, both with predetermined parameters, ultimately to improve continuous quality improvement and CAPA undertaken, corrective action, preventive action. It is also an NABH need. So you want to add or enhance a mode, whether it is treatment, whether it is a selection, it can be anything. Or you can delete a process or reduce the process to modify. All these things can be done with a clinical audit. That is the aim. So you want to analyze the delivery. You want to make a difference, improvement, patient care. So we would like to know what is the difference between an audit and research. I mentioned this in the first presentation. Yes, research is for a new knowledge, something we are going to do newly. It is going to be done, answer a specific question. It can be retrospectively collected and done, and then research. And now that all our DNB PGs know very well about this research and write wonderful thesis, we can use them for all these purposes. Clinical audit can be a final stage of research where you do fine tuning according to our local circumstances, but without crossing the limit, because we do not want a harm to be done like any unknown criteria. So the clinical audit will be first identifying a issue or topic, then set up a standard on what you are going to see, collect data, analyze, compare with the standard, implement the changes you want to improvise what you want to do, and then re-audit. If there is no problem, you can even do a third cycle. This is the basic. First, you have to prepare for audit, make a selection criteria, performances, making improvement, and sustaining. These are the steps. Dr. Janani has explained it in various slides, all these things. Most important, we have to have a team of clean, not only one person or two people deciding. The team in a bigger organization should be big enough. They must understand it is for the benefit of the patient and thought. So this is the first clinical audit committee we formed 3 years back under Dr. Ganesh Ram, and we started with 7 or 8 departments doing 7 audits. At the end, for the NABS, we had 2 or 3 good clinical audit presentations, and it is evolving and improving by the day. They must understand the process and commitment. They should know why to improve, enhance, or make a change. How to choose a topic? You choose topic which will be beneficial to the patient, to the doctor, and to the organization. High cost, high volume processes can be analyzed. Wherever the risk of a patient or the staff is also more. Cost factor, I told you. Better optimal outcomes. You may be doing good. It may be little better also. From 80, you want to make it 90, and based on standard guideline. This is something called the healthcare quality model, which is spoken across the world. There are 3 processes in healthcare. One is called the structure or the anatomy, physiology or the process, and finally the outcome. All the staff, equipment, patient supply, all these other necessities to do the healthcare. Then the doctor's orders, coordination, responses, processes, surgeries, investigations, all this will come into processes. Ultimately, clinical outcome, functional status, then the satisfaction index also is an outcome. I may have 6, but I say there is distortion because of my multifocal. That is not a satisfaction. That means my counseling was not proper prior to the surgery. And of course, happy with what was the cost. So these again, they should all be approved by some kind of professional organization, peer reviewed guidelines or local practices. Also, you can take without harm, no harm, you can improve. But there may not be improvement, that is okay. But there should not be any harm because of this. So whatever topic we take will be specific, achievable, measurable, achievable, realistic, and timely. That's what we call. So between research and whatever we do as a clinical audit, research we need a ethics committee approval. We need a separate consent from the patient. For a clinical audit, you don't need anything like that. So specific it should be a clear topic and ambiguous. It should not be ambiguous. Then measurable data. Without measurable data, you cannot do only objectively. Achievable by all concerned. Realistic, you should take the area of care and concern. Whichever is raised, for that only you take the standard, and it should be updated, new evidence based, and as per the various publication. It should be high volume, high cost, and so on. So sometimes there is a gut feeling in the surgeon who is very experienced. Is a funny paklam, but no harm will come. Say suddenly 0.5% timolol will become 0.25. That is one of the clinical audit effect. So standard is a statement what quality of care to be achieved, which is definable and measurable. So you need to have a criteria and a target. Simple example is 90% of the corneal ulcer patients will be seen within 30 minutes. That is one of the criteria. And the second criteria, 100% who have been advised will have scraping and syringing done. So this is simple. An exception is almost like a research, but it is a simple process to improve our outcomes, to make the patient. Waiting time itself is a big thing for the patient. And from the consultant point of view, you have your scraping done, syringing done, you don't miss on a dacryocystitis. After 1 week, they come and the corneal ulcer has become worse. We would have found that the syringing was not done. Endophthalmitis because the propla was not positive. So this is something. So data collection is the base data is the most important, based on which you're going to decide what are the changes to do. And then you do the data analysis, then you implement. So existing level of performances can be got by two ways. You don't have to get and wait for 2 months to talk. You can retrospectively also collect. And based on that, you implement changes. You tell the people concerned. You involve only a fewer people in the initial phase, not too many. If too many people are there, acceptance becomes difficult. Then you implement and follow it up with a period, usually 2 to 3 months only, and then you see. You also know what is the total number of cases, just like how they do a thesis. So you need, but it's statistically significant number of people. It the selection method also, it could be randomized. Everything can be made very simple. We don't have to go for higher level of analysis also. So the target degree of accuracy is needed and expected outcome. So this is something you need to have a proper form. It has to be in an Excel sheet. Analysis can be simple percentage, 20% to 30%, 20, 50 to 70, that is enough. But you're having more than one standards in one audit, then you need to have a more complicated analysis. The plot data will help. You also understand if there are gaps with respect to the individual group or the organization and address them. Intervention is done and changes are occurred. Then after the period of 3 months, you have to reassess if it is improving, if the changes are good, implement. How do you communicate to everybody? Then you have done it with 2 doctors. You want the entire department of 20 to do. Here is the major problem. So you have to talk to them also and write a written report. If you don't talk and just send an order, 60% to 80% will not follow. And this is the way, just like a thesis, I'm not telling anything new. All the aspects of the report are taken care, and this is the action plan. References and appendices should be there. All standards are met, you can only repeat to ensure it is being done. Only some standards are not met, you repeat data collection only for those not met, and again you do it. Repeat, if all standards are not met, you repeat or change. Conclusion cannot be reached, or you can stop the audit. So this is a simple way. It looks simple, do not have, the secondary centers can have only cataract. Apart from that, you can have even allergic conjunctivitis management. Any simple thing, whether it is a pre-op, other per-op, post-op, any of the structures, processes or outcomes can be taken, and it becomes easier to this. Implementing and sustaining is a bigger challenge. There should be change in the independent and the organizational. We have to tell them why we are doing, who's going to be the beneficiary, not only the patient, including the surgeon and the organization. The training becomes an important part following audit, and coordinate and monitor in initial stages so that it is carried on